what can I do for you, my friend? What kind of questions do you have?
Well, I have a questions about the future of cardiothoracic surgery. So basically, this is like the specialty that I want to do in the future.
Okay.
But everyone I talk about this to, they keep telling me go to for cardiology because the future is more towards minimally invasive procedures and interventional cardiology. But honestly,
Mhm.
like I see myself more in surgery because I love the surgical part in cardiothoracic surgery.
Okay.
So what do you think about that?
I think that's a phenomenal question and one that everybody that's going into CT surgery should be asking themselves. So I'm in vascular. Obviously, we have a little bit of crossover between cardiothoracic and interventional cardiology. I will say the field is definitely trending more towards minimally invasive as a whole. I don't know that there'll ever not be an instance where a cardiothoracic surgeon is not needed, but I can definitely see the volume of work that's available decreasing year by year. I still have some friends that were PGY5s that are going into cardiothoracic surgery next year. They're super excited for it. They feel that the outlook is okay for their trajectory of their career. But I think that the cardiothoracic surgeons as a whole kind of shot themselves in the foot by not jumping on the minimally invasive train. Because like for vascular, we basically incorporated all the endovascular treatment into our day-to-day learning, you know what I mean? And so much of what we do is actually better suited minimally invasive, better recovery time, better outcomes, that kind of stuff. If cardiothoracic surgery in the future went that way of incorporating that into their residency training, I think it would be incredibly beneficial because like you said, like some of the heart valves, et cetera, like you're not needing a big, huge sternotomy to repair that anymore. For a CABG, obviously nobody's going to be doing that besides a cardiothoracic surgeon. But on that same note, you have to think to yourself, if only, let's say, a handful of surgeries that I do are things that only I can do, that means that I'm only going to be doing those 3 surgeries for the rest of my life, essentially. Like a lot of CT surgeons, they're just doing CABGs like a couple a day or a couple a week, depending on how busy they are. Maybe they'll do an LVAD, maybe they'll do a valve here and there. I did a cardiothoracic surgery rotation back in my 4th year of med school, and I just wanted to see what it was like and get some exposure to it just because I figured it'd help with vascular. And honestly, a ginormous volume of what they did was CABGs every day. I mean, I felt like I could do it. Obviously, I couldn't because I didn't have the skills, the hand-eye coordination and that kind of stuff, but I felt like I knew every step to a CABG by the end of the month just because I did so many of them. So if you're looking for variety, I don't think CT surgery is the right specialty for you. If you're looking for consistency, however, some people like getting really good at a few things, then I think CT surgery is very solid for that direction. Obviously, everybody's a little bit different. That may make perfect sense to you and sound awesome, or that may sound terrible. I don't know. But certainly interventional cardiology, they even encroach on what we do with vascular from time to time. I mean, they'll be putting stents in people's legs. They'll be doing balloon angioplasties for peripheral artery disease, all kinds of stuff. And the problem is, and this is just my perspective on it, it's like if you have a hammer, everything looks like a nail, right? So if you only have minimally invasive, then everything you do is minimally invasive, whether or not it's the standard of care for the patient. And this is like super, super huge, especially now you got interventional neurology, you got interventional radiology who does neurovascular procedures. You have interventional nephrology, which is now a fellowship on top of nephrology. You have interventional cardiology. I mean, all these people are now starting to encroach into the minimally invasive sphere. I mean, we got people that are interventional nephrologists, meaning they have 0 procedural training, and they're out here doing minimally invasive endovascular fistula creation. I mean, it's just like absolutely crazy to see. And even with the interventional neurologists as well as interventional neuro IR, I mean, they'll be putting stents in people's carotids, and there's an astronomical amount of data that shows that that's not the best treatment for 90% of patients. The only time that somebody needs a stent in their carotid is if they're, number one, too sick to undergo open surgery, because you can do carotid endarterectomy, or you can do a TCAR, which is transcarotid artery revascularization, which still requires a cut down onto the carotid artery. You put like an embolic protection device and reverse the flow down into their femoral vein during the procedure. But anyways, you got all these interventionalists that are just treating everything with a stent or with a balloon that is not the standard of care by any means. And that was one of the reasons I went into vascular, is because it gave you avenue to treat both at the same time rather than just hammering everything essentially. And that's one of the things that I would be hesitant about going into an interventional non-surgical field, but also something you have to keep in mind about if you go into CT. Obviously everything that you have is a hammer and a nail again, but it's only for open surgery. So it's like, is this the best for the patient? You have to kind of weigh the risk and benefit profile of, can I tolerate a huge open surgery? Can they undergo sternotomy? Whatever it is. A lot of the CT surgeons I know, they even have transitioned a lot of their practice to thoracic. So they're doing like long resections, they're doing esophageal work. So it's definitely an option if you do cardiothoracic surgery, because like half your fellowship is going to be strictly thoracic, depending on which fellowship you go to. There's certain ones that are heavier on cardiac, others that are heavier on thoracic, but you do get that skill set, which is invaluable, because I think that will never go away no matter what. They just haven't caught up with the minimally invasive to the same degree for a lot of that stuff. But I know that was a really long-winded answer to your question. And
no, it was helpful.
I'm just some guy. I'm just one person. You know what I mean? So that's my insight from what I've seen in the hospital.
All right. So actually, I've read some studies about the outcomes of robotic minimally invasive cardiac surgeries, and sometimes they have better outcomes than interventional cardiology. Yet, like, I noticed that interventional procedures are more performed than robotic ones and are like preferred in reality. So that's a little bit confusing. And even like the future of the specialty, I feel that it's not sure. So sometimes I feel like cardiothoracic surgeons are going to interventional, and they can do interventional too, but sometimes I feel that there are some limitations to that. Like, for example, when last time I checked about the fellowships of interventional cardiology that were open to cardiovascular surgeons, I guess there were only 3 programs in the US. So that was a little bit confusing.
Yeah, I don't personally know any cardiothoracic surgeons that go back for additional training in minimally invasive, because by the time that you're done with all that fellowship and all that training, plus 5 years of gen surge, nobody wants to go back for more training. And I'll just give you my perspective, because I think it's always helpful to hear from a resident. I swear, man, there is nothing that could stop me from going straight into practice when I'm done. Like there could be the best fellowship that comes out on the face of the planet, and I'm not even putting my name down for it. Like, you just get so sick and tired of being a resident and you want to just do your own thing by the end. And I still got 2 more years of residency. Trust me, you just get super, super over it by the end of the day, because you start getting your skill level to a certain point where you feel you could learn just as fast by you doing a surgery with just another surgeon rather than being in a whole training program. You know what I mean? Like, because every single surgeon I spoke to, once they finish residency, your biggest growth is actually the year after residency. And that's when everything kind of rests upon you. It's like, is the patient going to make it? Yes or no? It's up to you. And there's like less busy work. There's less making presentations and stuff. I mean, I counted the other day, I made 50 presentations so far while I've been in residency. So like, everything you do is like solely revolved around helping your patient, making sure that they survive the surgery. And so your knowledge skyrockets because you're doing all the dissection yourself. Maybe you call in a senior partner if you run into trouble. Whereas like when you're in residency, you're kind of going hand in hand with your attending the whole time. And certain attendings are obviously going to let you do more, certain will let you do less. But yeah, I think that doing a interventional fellowship on top of CT surgery is hyper unrealistic.
Okay.
Because I remember like back whenever I was in your shoes, there's advanced aortic fellowships on top of the vascular fellowship. And you can really only do them for the most part in Europe, as far as I'm aware. And I remember thinking as a med student, I was like, oh, that'd be super awesome. You'd be like the best aortic surgeon in the planet if you did that. And once you actually get into it, you're just like, no way, bro. There's no shot.
Enough.
Yep.
You just say, yeah. I have a question, actually. Another question, please, if you have time.
Sure. And then I'll get to whatever questions Aylwin's got.
Thank you so much. So basically, like, I remember, like, I'm currently doing a remote elective in interventional cardiology with Mount Sinai, and
Okay.
I felt that there are so many common procedures between interventional radiologists and vascular surgeons. So, so if both specialties are in the same academic hospital, how do you split the roles of each specialty?
Oh, that's a really good question. So from my experience, whenever there's IR and vascular, most peripheral vascular disease stuff is going to go to the vascular team, because IR has so like a ginormous multitude of other stuff that they do, whether it's drains or GI stuff, et cetera, et cetera. I mean, they have like thousands of biopsies that they're requested to do per week. You know what I mean? There's just like an astronomical volume of stuff that they get asked to do. So a lot of the time they have like zero, what's the way to say it? Like they're totally okay with not doing the peripheral artery disease stuff because they just are so swamped as it is. It seems like IR is one of the most overworked specialties, at least from what I've seen, because there's so many teams that need them as a whole. We actually let IR do most of the vein stuff in my hospital, whether it's like thrombectomies or DVTs, that kind of stuff, just because we don't have the time to do the vein stuff. And it's going to be different everywhere you go. But if there's a residency training program for both, that's pretty much how it's going to be split up.
Okay.
Good questions, man.